Hello, this is Sabine Girod. I'm an oral maxillofacial surgeon at Stanford University, Professor Emeritus, and I'm very happy to be with you, at least virtually today, at the Sulambuco conference in Brazil. I thank the organizers for inviting me to speak about sleep apnea, and I will focus on sleep apnea in the orthognathic surgery patient. And I hope this is going to be interesting for you. This is where I am sitting right now. So this is Stanford University in Northern California in the United States. And on the right side down here, you see my team. At the beginning, I would like to thank them all because orthognathic surgery and obstructive sleep apnea surgery is not possible without an excellent team. You cannot do it alone. The surgeon is only part of the puzzle, and you only get good outcomes if you have good people around you and also your colleagues in ENT and plastic surgery at your side for the diagnostic and aesthetic improvements of our patients. I have no financial relationships to disclose in relation to this talk. I will mention companies, but I'm not involved with them. So the learning objectives today is really in connection. What I'm envisioning is, an oral maxillofacial surgeon who does a lot of orthognathic surgery. I think we need to be aware of the prevalence of obstructive sleep apnea because it influences not only our diagnosis and treatment, but also the perioperative problems that may arise. We need to a little bit to know about the indications and treatment options for obstructive sleep apnea, and also appreciate appreciate the role of virtual surgical planning as in obstructive sleep apnea as well as orthognathic surgery, because there are still some caveats that I want to talk about. It is very important in these patients to modify your risk management, especially perioperatively, and I will talk about that. I would like to make sure that after this talk, you understand that the obstructive sleep apnea patient is somebody who is hidden in your patient population and has a very different risk profile, and that you are able to safely operate on these patients and also use your skills to advance into surgery of obstructive sleep apnea, again, in connection with your colleagues, because this is a team sport. This is not something that you can do all alone in your private practice without anybody around you who can, look at all the other aspects of this multifactorial disease. I would like to start with two of my patients, and this is actually very typical. And I think also to my point. So above you see Michelle, she is 33 years old, and below you see Stephanie, 21 years old. If you look at the craniofacial deformity of these two patients, I think usually I ask my audience if it's live, who would do what. But, you can do different surgeries for them. Most likely you would think about a Lefort or, if you don't like the chin, a setback, maybe a Bimax. So, I mean, just from the craniofacial profile, I hope you will agree with me. They look pretty similar. But what is the big difference? So today, luckily, we use CBCT scans in these cases, and you can immediately see that there is a difference between Michelle and Stephanie. Michelle definitely has a very compromised airway, whereas Michelle looks like the airway is within normal limits. So this would actually then prompt us. So again, 80% of sleep apnea is undiagnosed, and there's prone to be a large percentage of patients in your craniofacial deformity, population, which is, in the largest sense, also patients who undergo orthognathic surgery. There will be patients that you haven't diagnosed if you're not actively looking for them. So, what is a good way to just, I'm thinking about, you are in your clinic, in your practice, in your hospital, you're seeing these patients. What is a good way to sort of get an idea? And I tell you later why I think this is a good idea. One of them is the Epworth sleepiness scale. You can just give it to them in the waiting room. I mean, they don't have anything to do other than fill out your forms, and that might be a good idea. to just get an idea of whether there is a problem. So this is one of the questionnaires that you can give out, and the other one is the so-called Stop Bang questionnaire, which is goes into a similar direction with different questions, and it has been validated and is highly correlated. So it's a standardized questionnaire that has been validated in different scenarios, so you can pretty much rely on it. I'm including QR codes down there, so if you have a chance, and I hope the QR codes are big enough on the screen that you can actually take a shot and get to these publications. If it doesn't work, send me an email later. So this specific questionnaire has actually been used in outpatient surgery offices in our maxillofacial surgery setting. And lo and behold, in the normal population, which is prone to be, your extractions, your implants, your wisdom teeth, and 77% of these patients may, beknownst or unbeknownst to you, have obstructive sleep apnea signs based on this particular questionnaire. So, if you're looking at this population versus the population that you see in your orthodontic surgery clinic, you can already imagine that the likelihood that you have patients in your orthodontic surgery clinic where sleep apnea has not been diagnosed is definitely higher than this. And in this population, it's already significant. This is really the point I wanted to make. Usually it's very easy, or not very easy, but there are hallmarks of patients who have obstructive sleep apnea, such as obesity, BMI over 30, male sex, particularly over age 40, risk in females increases with postmenopause, and of course, the whole gamut of craniofacial anomalies, plus the neck circumference. But don't rely on that. In fact, 1 in 4 patients who have sleep apnea have normal weight and are thin. And I always remember one of our residents who was a very fit, Navy SEAL. He actually was a Navy SEAL and became a plastic surgeon in our clinic. And he had sleep apnea, right? Nobody would have ever thought, but the man had sleep apnea, normal weight, very fit, none of these hallmarks that you see here. So, these are just hallmarks, but they don't basically cover the whole population. Expect that about 25% to you, have very normal parameters. Of course, obesity is the biggest problem. Yeah, and I think I'll talk about that later. It's highly correlated with weight loss, of course. And you can see here that where you are in Brazil, going towards 30% of your population now has a BMI over 30. So, of course, there will be a lot of people with sleep apnea, but I think we have to also think about that not all of these patients are actually a candidate for surgery. So in my mind and in my practice, I don't operate on anybody who has a BMI over 30. So they have to go in a weight loss program, bariatric surgery. Now, with the new medications, there is an option to do that. And I tell you why. So this is one of my patients who had an AHI of 85.8% before surgery, LSATs 86. He weighed 236 pounds. I can't tell you right now what the BMI was because I don't have his height. And post Bimax, he had an AHI of 19.7, which is another thing, a whole other talk that, sleep apnea is not all about cure. Sleep apnea is also about improving sleep apnea and making it easier for CPAP to work. His LSATs, and, he lost quite, 30 pounds, which was really great. And however, he came back about a year later and he had gained his weight back and his AHI was back. Yeah, so I think, this is something that is very specific in sleep apnea patients that are overweight. If the weight really also influences how much you can do. And there is only so much you can do with skeletal movements in a patient who is overweight. That's, the decision that people over 30, I don't definitely operate on. So another area of, that you need to be concerned about, especially in these patients, but also in the ones, remember, 25% are thin and look normal. They have an increased a rate of perioperative complications. Yeah. Reintubation after extubation, unplanned ICU transfers, respiratory failure, acute hypoxia, cardiac events, all because of the comorbidities that are associated with long-term sleep apnea. And that's bound to be more your older patients, but still, you need to be really aware of this, and this is significant. Yeah, this is very important to know. And this is why sleep apnea patients or patients with sleep apnea, when they come to your clinic and you don't realize what's happening, this is a major concern. So one of the preventive things that we are doing in these patients, and again, that can be a tool in your practice. You can actually download it or print it or do it for yourselves. Again, this is the publication by Camacho and Robert Riley and Robson Capasso, my friends here at Stanford. Every patient gets a questionnaire, right, where is a sign of sleep apnea, and all the medical issues are addressed before surgery and optimized as much as possible. Yeah, so I think it's always good to have sort of a standardized approach so that you don't forget everything, and also your team and your nurses, your physician assistants, and your medical personnel is trained to basically make sure that all of these patients undergo an optimized workup so that you don't run into problems during and after surgery. Perioperative risk mitigation. There is a really nice article by my colleagues Riley and Powell, who are retired in the meantime, about obstructive sleep apnea, surgery, risk management, and complications. The article is slightly older. It's 2016 in the Otolaryngology Head and Neck Surgery. But they looked at, so all they did was sleep surgery, right? So obstructive sleep apnea. And they looked at 182 of their patients, and they found that in almost 18%, they had difficulties with intubation and strongly correlated with neck circumference. And it is very important that you have the ability and a team that's actually educated in difficult airways, because the strategic use of awake fiber optic intubation markedly reduced airway-related complications, which you don't want to have. They also strongly advocate that all these patients go to the ICU, but are extubated in the operating room. Yeah, I mean, you're improving the airway, so there's no need to bring the patient to the ICU intubated. And intubating these patients in the ICU is much more perilous, especially since you have increased swelling over the next days, is much more perilous than extubating the patient in the operating room under controlled conditions with the possibility of a tracheostomy if it doesn't work. So again, I think we are using a team that is specialized in difficult airway. And there's another very nice publication here that talks about the difficult airway algorithm. I think one of the co-authors is actually the colleague that I always worked with at Stanford. I think it also has the additional, if you work with a team that's experienced, usually that's a specialized team, at least at Stanford that is, there is a team who specializes in difficult airways, and you can actually request them. Yeah, and in general, I requested them. That had the additional, for me, the additional benefit that I always got the same anesthesia team. And, if you think about, also, keeping the blood pressure under control and all of these things. So these people were really, in their experience, more advanced and, in terms of airway and the cases I was doing than all the others. And that was just a great comfort and wonderful to work with them. Again, it's not only you, it's the team, and it makes life better for you. So just in general, I mean, there are tons of treatment options for sleep apnea in the web, and I always feel that if there are a lot of treatment options, some of them sound bizarre. It's a multifactorial disease, and we cannot really pinpoint in each individual case what we're doing. So diagnostic workup in sleep apnea. That's another thing. You need to have some sleep medicine doctors who work with you, because it's very complex. It's not just one size fits all. Every patient is different. You need to you need to develop a treatment plan based on all the factors that you see in your patients. I just wanted to emphasize here again that if a patient has a BMI over 30, consider weight loss or medication, definitely reduction in weight. Let's go into the surgical planning. We're all using virtual surgical planning these days. I think it's come a long way. I'm always a little bit amused when people talk about 3D because we are usually looking at 2D images that we drive around. So I mean, there is a little bit of a yeah, what should I say? A confusion in the in the description or the vocabulary, the language we are using. But what we cannot do really today is sort of have this kind of thing that you just saw, where we actively manipulate and the soft tissue follows. But I mean, there are plenty of them around. There's a nice over article by Brian Bell on this. So, but think about, let's go back a little bit. Think about, soft tissue simulation. I mean, we're using it, and some of the systems that we're using today, they pretend to they simulate the surface, right? And also, the airway. You just saw at the beginning that we had a static positioning of the airway. Just think about the airway for a moment, and also think about the face. If you take your CT scan in an upright or supine position, that will already make a difference, right? So if a patient lies down, lo and behold, I think the airway is going to collapse a little bit. So if you have sleep apnea patients, or it's much better to scan them in a supine position if you can. Usually the CBCT scans are upright. And then there are these studies, retrospective studies, compare the correlation of skeletal movement and airway volume. What does it really tell us, right? So yes, we see a picture where the airway is bigger or smaller, but what you don't see is lateral collapse or anything like that. There's absolutely no dynamics. And I'm sorry to say, but if you put this thing in and then do a statistics, I mean, for me, this is really, I mean, it's nice, but it's really not. Yeah, I mean, what does it really mean, right? Is there a correlation? Because we're looking at a three-dimensional structure that is very dynamic. Yeah, yeah, so I don't know whether that means anything, except for nice pictures. The same is true for especially the upper jaw, right? So if you move the upper jaw, all these soft tissue simulations don't really represent, the real situation, especially in the upper lip. And I've seen a lot of complications now or problems because people do virtual surgical planning without actually looking at the patient and asking the patient to do the dynamic movements. I mean, this is luckily still something that we as surgeons have to look at. And measurements are nice, but they don't tell you how far somebody is smiling. Do they have a gummy smile? Do I need to impact more? If they don't have a gummy smile, I impact too much. Are they going to look like 100 years old? These are still things that you really need to look at your patient. I mean, your virtual surgical planning will not tell you, and that is a big problem. And a lot of people, run into that because you can rely on numbers, but don't rely on them too much. Even more complex is the oropharynx, right? I mean, look at this, right? This is all soft tissue, muscle, and it really requires, requires 4D imaging, functional imaging. And of course, in the last couple of years, the drug-induced sleep apnea has become very popular, which is, I think if you do it and you look into the oropharynx and you see when you move the lower jaw forward, there is an opening and things like that, which is really nice. And I mean, it gives, I assume, I don't do them myself, but I think it gives the surgeon sort of an idea, and especially the jaw thrust gives you an idea if you move the jaw forward that there will be some improvement. And the patient is sleeping, or, I mean, there is a difference, of course, between sleeping and sedation, but, as close as we can get. The problem is really that there's no universal classification scheme, and you cannot really, put any data on it. So I think it's very subjective, and they cannot predict surgical results because of the lack of data, landmarks. So another thing is, if you have a patient, think about Michelle and Bettina at the moment. Michelle has sleep apnea. Oh, the question is always, what are we going to do there? How far do we advance? I think the general consensus is, that 10 to 15 millimans advancement gives a 95% cure rate. But interestingly enough, what is called cure rate is sort of the goalpost is shifting, right? So people define that a little bit different. And it's a very variable thing. And in one case, that's very somebody who is very thin, this might be the case. But in somebody like the patient that I showed you before, who is fluctuating in his weight, these 10 to 50 millimeters may lead to a completely different outcome because of the weight issue. Yeah, so I think it's a little bit sort of a moving target there. So it's not like orthognathic surgery where you have a patient and you can plan kind of the airway is a much more complex issue and more complex than the facial surface that we just talked about. Efficiency is very good. Improve. There is a great, study here. We still don't have a long-term follow-up that much, but I think in most studies today, everybody agrees that maxillomandibular advancement is sort of the best tool in the box that we have. Let's come back to how much to advance. Yeah, so it's really also a conversation with your patient. So and I show this because I was very unhappy and the patient was very happy. So this is actually a patient of mine who had severe sleep apnea, and he was a pilot, and pilots, as you may know, if they have sleep apnea, cannot fly. So he said, do everything. And you see also he was very thin, right? So is very thin. And do everything you want. I don't care about what I look like. And so we didn't care what I look like. And, so post-operatively his AHI was 1.9. And of course, he had terrible aesthetic problems, even though we did a rotation advancement, right? We just moved him as much forward as we could, because in this case, the patient wanted to go back to flying and he didn't really care what he looked like. And later we also had, he had some nose cosmetic correction. But, I think this is also very important to know. You have to talk to your patient, what are his or her goals? So that you can do that. Otherwise, you're also going to get into trouble. He was happy. This is another patient, typical craniofacial case. I mean, you look at this, you already know that there is an airway problem. Yeah, and then, this is the post-operative outcome. This is one of the cases that make you feel good. You have a young woman, before and after, and, you basically, completely change her outlook and her life. She is still only 3 weeks after surgery in the post-ops, and still a little bit swollen. So I think the swelling and I could have done a chin. I did a chin, but I could have put her a little bit more forward. So that is my personal criticism. But she was very happy in comparison to before, and her sleep apnea was also gone at the time. So these are the facial, again, I think I talked to you about the facial dynamics in the beginning. Remember the slide where I said, the lips and the nose isn't really simulated. You can see that really well in this patient. If you look the simulated results, up there are the beige ones, and the actual outcome of the beige ones and the blue ones, and the actual outcome, you see that the tip is no longer hanging, but the tip is now up because we moved the upper jaw also forward in her, right, or impacted her. And that is very important to know. You see the difference between that these areas in the face are not simulated in your soft tissue simulation of the surface. Okay. Let's go back. Let's close the loop at this point and, look at Michelle and Stephanie. So this is Michelle. She has sleep apnea, as we now know. This is her post-operative occlusion. And what did I do? I actually moved her upper jaw and her lower jaw forward both. Yeah, and you would have thought maybe when you looked at the initial pictures, she is crazy. She's going to look terrible. Yeah, but I think we needed to address her sleep apnea, but we also needed to give her a good outcome. So we didn't move her forward that much, but it made a huge difference, right? Her airway all of a sudden doubled. Yeah, I couldn't have done that. We needed, because she has base of tongue obstruction as well, we needed to bring the lower jaw forward. And this is Stephanie. Yeah, and Stephanie here is pre-op and post-op. In her case, I think I only did an upper jaw. Yes, I only did an upper jaw. Yeah, so I think, it is very important to look at your patients and also plan according. Sleep apnea is a big, big thing. I don't know whether I have done a mandibular setback in the last, I don't know, I mean, for years, because if we have a too prominent chin, I'd rather do a reduction genioplasty or something like that. But in general, in the population that I've been seeing, I didn't need to do that in the many cases. I think except for, very large jaws, and we did setbacks, but always very conservative, because we now know that we don't want to create sleep apnea problems in the long run. I think, again, I want to come back to something that I said in the beginning. One size doesn't fit all. Our priority is to integrate all the tools we have in a personalized approach. And again, that comes back to, you ask your ENT colleagues, your sleep medicine colleagues, you ask yourself, and your team needs to be educated. You all need to work together to create a plan that takes all the little, cornerstones into account to create a cohesive surgical plan for a patient, which we talk about, which we call, of course, in this day and age, with another buzzword, precision surgery. And I think this is very important, and this actually will give you good outcomes. This is one of my patients, and she sent me obviously, I mean, you see, I show you the next picture. This is what she looked like before. She had a class 2 sleep apnea and whatnot. And then she sent me her picture afterwards, after the surgery. And this is her. I mean, of course, it's airbrushed, yeah, but I mean, you can see just she's very happy. She is alert. She looks great. Her sleep apnea is gone. And I think, this is really what we are all aiming for. And this is only possible if you do good diagnostics, if you understand your patient population, if you look at every patient from every angle, ask them what they want, and then come up with a plan together with your patient that you all go through with, and with your team. So again, let's summarize. The pathophysiology of sleep apnea is multifactorial. You need other people to tell you in their specialty, sleep medicine, ENT, where the problems are in a particular patient. The upper airway is usually evaluated when the patient is awake. Think also about the imaging. So, when the patient is sleeping, it's prone to be worse than what you're seeing. One of the big problems in obstructive sleep apnea surgery is that the majority of studies are case series. I just saw a review, and they included they evaluated 380 studies, and only 31 could be included in the meta-analysis, because most of them are not have biases in regard to patient selection, sample size, and follow-up. Yeah, so there's a huge need to do good studies and continue on that route. There's an unclear definition of successful treatment. I only briefly alerted to that. I think that as opposed to orthognathic surgery, where, you need to get the teeth in a correct position and want to have an aesthetic outcome, treating sleep apnea is much different. Remember, the patient with a weight who then came back and had his original sleep apnea after a big surgery because he gained another 50 pounds. Yeah, so that is a very, very, very unclear. And also how much to advance in an individual case is experience in my thinking, not so much as measurements. Yeah, so I mean, you saw in Michelle that I sort of moved her forward, hoping and thinking that she would still look good afterwards. And she did. And, this is something that I think we're still the human factor, the surgical factor. As a surgeon, experienced surgeon, you make the decision, right? The key for success is correct patient selection always. Yeah. So, but this is something that you already know, but it's even more important for patients in your practice who have obstructive sleep apnea. If you want to learn a little bit more and get updated, I recommend that you read the International Consensus Statement on Obstructive Sleep Apnea. Everything is written in there. It's a very good, gives you a very good update. It's fairly recent from 2022, so it's a great thing to look at. Last but not least, let me make some remarks in the personal. So we, as a group of 25 surgeons, have founded Surge On a couple of years ago, and it's a free platform. All of the live content can be accessed for free. And if you go to the website, you can actually see more sleep apnea talks from some of the world-renowned surgeons, and they will also come back for case discussions. For example, Casey Lee, my friend here from Stanford, or Shannon Sullivan, and Fernanda Alameda has a fantastic presentation on the site about dental treatment of obstructive sleep apnea. So look at it. There are live events every Monday, and we have over 100 videos. I think, as you see here, 8 of them about sleep apnea. So you can, listen to different people that cover the whole spectrum of what you might be interested in. With that, I would like to thank you. If you have any more questions, please email me. I'm also happy to send, the papers that I cited here. And again, I would also like to thank my team on the left side here that has been working with me for a long time. And as I said, I'm very grateful that they are so wonderful to work with, and that really made a huge difference for our patients and our outcomes. Thank you very much, and have a wonderful day. I'm happy to answer any questions right now.